Hello and welcome to the video training for the AlcHepNet clinical trial. This is a slide of our course staff. The IND holder is Dr. Samer Gare from the IUDCC, and the NIAAA officer is Svetlana Radeva. This first portion is meant for principal investigators and sub-investigators. So the objective and study design. The objectives and design, the multi-center, randomized, double-blinded, placebo-controlled clinical trial is focused on novel treatments for severe alcoholic hepatitis, which is a life-threatening stage of alcoholic liver injury that has a short-term mortality rate much higher than that of other liver diseases. The primary objective of the study is to determine the clinical efficacy and safety of anakinra plus zinc and the granulocyte colony stimulating factor, also known as GCSF, compared to the current standard medical treatment consisting of prednisone in participants with clinically severe alcoholic hepatitis. The key secondary objectives broadly are as follows: to evaluate the use of biomarkers to assess disease severity and treatment response, and to develop the novel endpoints to overcome the limitations of current assessment strategies for severe alcoholic hepatitis. The proposed study is a phase 2b multi-center prospective randomized 3-arm double-blinded placebo-controlled clinical trial to assess the efficacy of anakinra, an interleukin-1 receptor antagonist plus zinc, versus the GCSF compared to prednisone for the treatment of severe AH with the MELD score of greater or equal to 20. All participants will receive standard care for treatment of severe alcoholic hepatitis as described in recent guidelines endorsed by the American Association for the Study of Liver Diseases and the American College of Gastroenterology. The study will be conducted at 8 clinical sites across the United States, selected by the National Institute of Alcohol Abuse and Alcoholism, and will be supported by a data coordinating center at Indiana University. The biorepository will be managed by the University of Massachusetts. Primary and secondary endpoints of the study. The primary endpoint is survival at 90 days. Secondary endpoints are changes in scores, the LIL score, the MELD score, development of acute kidney injury, multi-organ failure, SIRS, transfer to ICU, changes in liver function will all be evaluated at 7, 30, and 90 days. Organ dysfunction, measure of changes in the sequential organ failure assessment scores and proportions requiring hemodynamic support for a MAP of less than 65 and lactate greater than 2, renal replacement therapy or mechanical ventilation. The SOFA score will be modified and reevaluated without platelet counts, given that these are usually low in alcoholic hepatitis. Infections and sepsis. The endpoints and case definitions related to sepsis may vary depending on what will be used: clinical care, research, surveillance, or quality improvement. Given the central role of sepsis as a driver of outcomes, measuring the types of infection will occur, but also identify the proportions of those with sepsis, septic shock, or quick SOFA criteria based on the Sepsis 3 guidance. Key parameters will be captured and needed for various sepsis-related endpoint construction aligned by the recent guidance from the European Drug Development Hub. Renal dysfunction. In alignment with guidance from the Acute Disease Quality Initiative, the AKI development will be quantified and its progression through persistent AKI, acute kidney disease to chronic kidney disease. any need for care escalation, proportions of participants requiring transfer to ICU for care, intubation for airway control, need for ventilator support, or RRT, monitored at all time points. Indicators of gut permeability, endotoxin and bacterial 18S DNA, and pro-inflammatory cytokine chemokines will be assessed in serum and plasma samples, and survival at 30 and 180 days. Our enrollment goes, the 387 subjects with 129 per arm. Each site will enroll 49 participants, and the enrollment period is 5 years. Our accrual goal for 2019 was 6 to 12 participants per site, adjusted as the starting time point is adjusting. Our study medication is prednisone, zinc sulfate, and placebo oral therapy. The prednisone is 40 milligram capsules. The zinc sulfate is 220 milligram capsules, and the placebo for prednisone and zinc will be over encapsulated by the University of Iowa for this study. Anakinra, filgrastim, Sandoz, and placebo subcutaneous therapy. Anakinra, which is 100 milligrams per 0.67 milliliters. These are in pre-filled syringes, and they will be purchased by the IU Health Investigational Drugs Service through the wholesaler Cardinal Health. The GCSF, 300 micrograms in half a milliliter, or 480 micrograms in 0.8 milliliters, are also in pre-filled syringes. The placebo for both the anakinra and the GCSF will be pre-filled syringes purchased directly from Sobi Pharmaceuticals and distributed by IU Health Investigational Drug Service. The GCSF is for both strengths of both the 300 and 480. Our study arms, after ensuring that participants meet all of the inclusion criteria and none of the exclusion criteria, and after the informed consent has been obtained, participants will be randomized to receive one of the following interventions in addition to standard of care. Group 1 is standard of care plus prednisone 40 milligrams orally once daily for 30 days. And then the matching placebos for both the GCSF and anakinra, which is 1 syringe subcutaneously twice daily for 5 days, and then 1 syringe subcutaneously once daily on days 6 through 14. And also the placebo for zinc, which is a matched pill to the prednisone for days 31 to 90. Group 2 is a standard of care plus the anakinra once daily for 14 days, and the zinc sulfate 220 milligrams once daily for 90 days, and the matching placebo for the GCSF, which will be 1 additional syringe subcutaneously every evening for 5 days on days 1 through 5. The prednisone placebo is presumed as part of the oral capsule for 30 days. Group 3, standard of care plus the GCSF, which is weight-based subcutaneously every 12 hours for 5 days, and matching placebos for the anakinra, which is 1 syringe once daily on days 6 through 14, and for the zinc and prednisone, which is the 1 matched pill containing both placebo for both prednisone and zinc days 1 through 90. The weight of 60 kilograms and less will be the 300 microgram dose, and the weight that's greater than 60 kilograms will be the 480 microgram dose. A dosage adjustment will only occur if weight change is greater or equal to 10% from baseline. Here is a visual schematic of the study arms. We will be instructing the patient on the self-administration of these experimental treatments if they are discharged, after they are discharged from the hospital, and we will make sure that they are proficient in these techniques. The inclusion and exclusion criteria. Our inclusion criteria is alcoholic hepatitis as defined by the NIAAA Pan Consortia for Alcoholic Hepatitis. The onset of jaundice defined as serum total bilirubin greater than 3 milligrams a deciliter within the prior 8 weeks to screening visit. The regular consumption of alcohol with an intake of greater than 40 grams daily or 280 grams weekly on average for women, and greater than 60 grams daily or 420 grams weekly on average for men for 6 months or more with less than 8 weeks of abstinence before the onset of jaundice. The consumption intake will be measured from several sources, including the timeline follow back, which the patient reports any reported alcohol intake through the electronic medical report system, and also any report by immediate family. AST is greater than 50 international units a liter. The AST and ALT ratio should be greater than 1.5, and both values should be less than 400 IU, and or histological evidence of alcoholic hepatitis. The MELD will be 20 to 35 on the day of randomization. So for the histological evidence would be a liver biopsy if the co-founding factors is not directly present, that it is alcoholic hepatitis. The biopsy should be from the current hospital admission. Our exclusion criteria is MELD score less than 20 or greater than 35, active sepsis, which would be positive blood or acidic cultures with the SIRS or hemodynamic compromise requiring intravenous pressors to maintain tissue perfusion. Any pneumonia as evidenced by radiological exam, multi-organ failure, renal failure defined as a GFR of less than 50 milliliters a minute, any clinically active C. diff infection, history of imaging of the liver, which shows any other cause of jaundice, history of other liver diseases, including hepatitis B, hepatitis C, autoimmune hepatitis, Wilson disease, genetic hemochromatosis, alpha-1 antitrypsin deficiency, or strong suspicion of drug-induced liver injury. History of HIV infection, history or presence of cancer, including hepatocellular carcinoma other than non-melanoma skin cancer, history of other significant medical problems such as autoimmune diseases, severe asthma, psoriasis, inflammatory bowel disease, etc., that might require immunosuppressive treatments. Pregnancy or breastfeeding, prior exposure to experimental therapies in the last 3 months, prior exposure to systemic corticosteroid or immunosuppressive therapy for more than 4 days within the previous 30 days, any need for inotropic pressor support to maintain perfusion to critical organs within the prior 48 hours before randomization and initiation of experimental treatment, clinically significant pancreatitis, abdominal pain, elevated lipase greater than 3 times the upper limit of normal, and at least edema of pancreas with fat stranding on the CT scan. Total white blood cell count of greater than 30,000. known allergy or intolerance to therapeutic agents to be tested, which does include latex, inability to voluntarily obtain informed consent from participant or guardian, perceived inability to follow study procedures and comply with protocol, and a platelet count of less than 50,000. The screening period will consist of less than or equal to 7 days prior to the randomization visit. During the screening period, participants' eligibility criteria must be confirmed. Patients with a clinical suspicion of sepsis will have an initial run-in period of 48 hours while being screened for eligibility for enrollment. Patients with evidence of sepsis will be excluded from the regarding the clinical suspicion of sepsis and the 48-hour run-in. Almost all alcoholic hepatitis patients are screened for infection upon admittance to the hospital. Per Dr. Gare, this means that it should be at least 48 hours post-admission and after all infection studies have cleared for the patient to be enrolled. Our visits. Our participants should be instructed to fast overnight at least 8 hours immediately prior to all clinic visits, including the screening visit. While fasting, water is permitted. However, the screening visit at the next amendment, the requirement to fast will be removed before screening. So our visits, again, are screening. The treatment phase is day 0, day 3, day 7, day 14, day 28, day 60, and day 90, with a follow-up visit at day 180. To review the protocol, our visits will include history and physical examination. Anthropometric measurements will be added at the next amendment. Laboratory examination, questionnaire administration, dispensing of the study medication, and biospecimen collection for biorepository, all visits except screening. Currently, by the way, study medication is being dispensed at day 0, day 3, and day 28. However, for outpatient visits at the next amendment, we will be adding a day 7 if needed, and we will discuss that later. Our questionnaires: timeline follow back, audit, chronic liver disease questionnaire. Specimen banking is including blood and stool, day 0, day 7, day 14, day 28, day 60, day 90, and day 180, and when available, urine and liver biopsy tissue. Blood will be used to extract germline DNA at baseline and at day 180, as well as to extract serum plasma PBMC at all visits. Saliva will be collected at day 0 and day 90. This is a slide of how much and when we are collecting each sample. This is the schedule of events. Please note that the questionnaire box was not checked. Here, that is just a typo. We are doing the timeline follow back questionnaire at screening. If you notice that is not checked here, but there is that questionnaire at screening. Unblinding procedures. Non-emergency unblinding is discussed in detail in the protocol. For the purpose of this training, we will focus on emergency unblinding only. In the event of a medical emergency that necessitates unblinding, the site investigator will contact Dr. Gare to discuss the rationale for the unblinding. If there is a difference of opinion as to the unblinding, Dr. Gare will defer to the site investigator, who retains the final right to seek unblinding. The site investigator will communicate with the DCCIU about the decision to unblind the participant, and then the DCCIU will unblind the participant by interacting directly with the designated site sub-investigator. So we have rules for unblinding participants for leukocytosis and concern for infection and sepsis on day 0 through day 30. If the participant develops leukocytosis greater than 30,000, the clinical care team may request unblinding if the team believes that knowing the treatment would impact care decisions such as starting antibiotics. If the participant develops hypotension and/or requires transfer to an ICU, again, the clinical care team may request unblinding if the team believes that knowing the treatment would impact care decisions such as administration of pressors, fluids, or other supportive therapy. If the participant develops any other serious adverse event that is, in the opinion of the investigator, probably related to one of the study drugs, the clinical care team may request unblinding if it would impact care decisions. Who will be unblinded? Only the designated sub-investigator, the clinical care team, and the DCC contact. Unblinding procedures, each site will designate a sub-investigator who can be contacted if the participant care team has concerns about rising leukocytosis. The contacted sub-investigator will communicate with the DCC to unblind the participant, then inform the participant's care team of the study drugs that the participant is receiving. The IU DCC will build this into the database system and keep track of unblinded participants. The decision to begin antibiotics for possible infection is left to the judgment of the clinical care team. To note, it has been discussed that if the clinical care team is unblinded, the potential for the investigators and study coordinators to be accidentally unblinded while reviewing electronic medical records is a possibility. So we will have a procedure in place for reporting accidental unblinding. Our drug holding rules for day 0 through day 30. If one of the following is met, the drug should be held for 3 days. So documented infection, which is pneumonia defined as new infiltrate by chest x-ray or chest CT scan, any positive cultures of blood or ascites for bacteria or fungus, and any positive fungal cultures in urine of greater than 50,000 colonies a milliliter. SIRS, which is defined as 2 or more abnormalities in temperature, increased heart rate, respiration, or white blood cell count, with an increase in the SOFA score greater or equal to 2 points SOFA. Participants will be reassessed on the 3rd day to determine if study drugs could be resumed or should be stopped. Protocol deviations. There will be 2 types of protocol deviations for the AlcHepNet studies, which would be a subject protocol deviation or a study protocol deviation. When a protocol deviation that affects the patient's safety is identified, notify the site investigator, complete the appropriate deviation form, which would be the subject protocol deviation form, which is also entered into REDCap, and the study protocol deviation form, which should be emailed to IU within 2 business days. More instructions will be in the manual of procedures, and report protocol deviation to the local IRB per local guidelines. Of course, we are recording all deviations, but it's just important to point out that safety deviations should ensure a immediate 2-day notice to IU. Relationship of any AEs or SAEs to study medications. The investigator will document his or her opinion of the relationship of the AE to treatment with study medication using the criteria outlined in the table below. An AE for which there is a reasonable possibility that the study medication caused the AE is otherwise referred to as a suspected adverse reaction. And reasonable possibility does mean that there is evidence to suggest a causal relationship between the study medication and the AE. SAE reporting. All SAEs must be reported to the DCCIU, which is Dr. Gare. and Savannah Yarnell within 2 working days after the investigator identifies the SAE. SAE should be entered into the REDCap system within 2 working days of the investigator becoming aware of the event. An initial report by telephone should then be followed as soon as possible by the completion of the SAE, CRF, and REDCap. Any supporting source documentation should be emailed to the assigned contact information as soon as possible. At a minimum, the following information should be provided at the time of the initial report: the 5-digit study ID, a description of the event, at least one criterion classifying the event as serious, and the name and title of the reporting individual. Additionally, judgment of causality by the investigator must be provided as soon as possible to ensure timely reporting to regulatory authorities. The site investigator will assess whether the event is causally related to the study medication. The study designated physician, Dr. Garay, will consider the investigator's assessment. However, since Dr. Garay holds the IND and is primarily responsible for the overall safety of the participants, his causality assessment will take precedence over that of the site investigator. The study designated physician, which is Dr. Garay, will determine if an SAE meets the criteria for an IND safety report, which would be a suspected unexpected serious adverse reaction in accordance with FDA regulations. We will monitor all safety closely, including all SAEs, acute kidney infection, or injury, and infection. We will provide unblinded data on SAEs, including infections and AKI, to the DSMB on a monthly basis, and will hold the first DSMB after 3 months from the start of enrollment. We also propose a risk-based monitoring approach, which will create a more efficient and timely monitoring of accumulating data on the adverse events of interest, namely acute kidney injury and infections. So here is a slide to follow SAE reporting, just kind of gives you step by step for easy reference. Pregnancy reporting: if a female participant becomes pregnant, she must stop taking study medication and must be withdrawn from the trial. The participant must be followed by the investigator through the end of her pregnancy. The mother and infant will be followed as considered appropriate by the investigator and the study designated physician. For reporting purposes, pregnancy is not considered a serious adverse event, and follow the WERB guidelines for a protocol deviation report. Here is a timetable of SAE reporting, who, in what time frame, and it lists the AEs, TEAEs, SAEs, and SUSARs, and fatalities. Here is another schematic of SAE reporting. Important to note that it does have Dr. Garay's cell phone at the bottom, or in his absence, Dr. Chalasani, to confirm causality reporting before reporting in the Excel table, or MedWatch form to other stakeholders. Here is a contact list for SAE and SUSAR reporting. This is a list of who is on our data and safety monitoring board. The frequency of their standard meetings will be every 6 months. So the Manual of Clinical Operations and Best Practice Guidance for the AlcHepNet clinical trial. The purpose of this Manual of Clinical Operations is to provide guidance on best practices on the management of sepsis, use of vasopressors, albumin, ICU care, mechanical ventilation, nutrition, and alcohol use disorder in patients with alcoholic hepatitis. The Surviving Sepsis Campaign, international guidelines for management of severe sepsis and septic shock, as well as the AASLD and ACG guidelines on management of alcoholic liver disease are the source of the recommendations for the guidelines within the MOP. We recognize that in real practice, clinical care is individualized according to each patient's conditions and needs, and there are variations in practices across different institutions and regions across the U.S. While it is difficult to protocol the approach to each of these complications and conditions in this sick population across 8 sites and their affiliated hospitals across the U.S., the hope is that the general guidance will be a useful guidance to investigators and clinical care teams to increase uniformity of approach. Although the management of these complications will not be mandated by protocol or this MOP, the clinical care provided will be recorded to develop novel designs for future trials and for practice guidance and quality improvement programs. The Manual of Clinical Operations and Best Practice Guidance of the AlcHepNet trial. The sections in the manual are the general principles of sepsis management, which includes the initial resuscitation and infection issues, screening for sepsis and performance improvement, diagnosis, antimicrobial therapy, source control, infection prevention, fluid therapy of severe sepsis, vasopressors, inotropic therapy, corticosteroids. Other supportive therapies in sepsis are covered the blood product administration, immunoglobulins, selenium, mechanical ventilation of sepsis, including ARDS, stress ulcer prophylaxis, nutrition, and setting goals of care. In addition, the manual contains additional comprehensive sections on alcohol use disorder and alcoholic liver disease screening and management, and the diagnosis, prognosis, and treatment of alcoholic hepatitis. This document should be kept in the study files and shared with co-investigators, coordinators, and with the ICU and hospitalist services at each of the participating sites. References below will be available on our AlcHepNet study documents on Box. So that concludes the PI sub-I portion of this training. Of course, you're more than welcome to stay for the remaining of the training. However, this portion will be focused on the coordinators. And if you are leaving us, thank you so much for your participation, and we look forward to working with you. So recruitment. The study population will be comprised of men and women of all races, ethnic groups, and socioeconomic status between the ages of 21 and 65, admitted to the hospital within a clinical diagnosis of alcoholic hepatitis. Identification of the participants with severe alcoholic hepatitis requires collaboration with those physicians who manage these participants within the hospital in the emergency department. It's anticipated that almost 100% of participants are admitted to hospital based on the severity of their liver disease. Occasionally, participants will be seen in freestanding urgent care centers, freestanding emergency rooms, or in office clinic practices. Since the standard of care is to admit these participants for further evaluation to exclude infections as precipitating cause of decompensated liver disease, most will ultimately be identified in a hospital setting. Letters will also be sent to referring MTs and referring hospitals. Compensation is site dependent. Please discuss with your primary investigator what would work best for your location. IU is compensating with Walmart gift cards at $50 per completed visit. Our study visit procedures. So our screening visit is the participant or legally authorized representative is to review and sign the informed consent document. Informed consent must be obtained from the participant or legally authorized representative before performing any trial-related procedures, including screening procedures. That would include asking anybody, of course, to fast if for some reason you were drawing any screening labs. However, we are removing that from the protocol, so that should not be an issue with screening. Verifying inclusion and exclusion criteria for eligibility, assessing the MELD score, collecting medical history, including the alcohol consumption specifics. Again, we are not utilizing the timeline follow back only, so that should help us. Record vital signs, including the height and weight, recording the prior, so within 30 days of day 0, and any current concomitant medications, performing a baseline standard 12-lead echocardiogram, assessing the availability of any liver biopsy samples, if applicable, which may have been obtained as part of standard of care, obtaining blood samples for the serum chemistry, hematology, hepatic function panel, and coagulation tests, performing a serum pregnancy test in females of childbearing potential, having the participant complete the timeline follow-back questionnaire, and reminding them to fast 8 hours prior to their next visit. Study identifiers are the same as in the observational trial, and it is actually just a continuation of the observational trial. So that should be easy for us. There is only one number. There is no separate randomization number. Any screen failures, if the participant signs the consent but does not meet eligibility criteria, the subject will be considered a screen failure. So complete the new subject registration form, complete the eligibility form, enter them into REDCap. If any samples were collected, please keep samples and ship quarterly as normal. So this could include the biopsy tissue, or a patient was screen failed after the day 0 study labs were drawn. Please do not discard those. Please do continue to ship those as you normally would. So day 0 procedures. So we have to do our best to try to maintain the 8 hours prior to any procedures being done for labs, the fasting. However, we do recognize that this will be difficult, especially in an inpatient setting. So we will just continue to do our best to try to maintain the 8-hour screening before the study procedures, or 8-hour fasting, before study procedures. And again, if you are encountering frequent difficulties with certain subject study procedures, such as fasting, please keep a record of these and send them to us. This will help us modify future versions of the protocol, and we'd like to know what difficulties you all are encountering, just like we did in the observational portion of AlcHepNet. So again, collecting any medical history, including alcohol consumption specifics, having a physical examination, recording the vital signs, including weight. The 3 questionnaires are to be completed at day 0, so the audit, the timeline follow back, and the CLDQ, and assess and record any pre-emergent AEs, recording, again, the con medications for the last 30 days, if there are any changes from screening, performing a urine pregnancy test if greater than 1 day since screening pregnancy test in females of childbearing potential, confirming that the inclusion and exclusion criteria for eligibility have been met, assessing the MELD scores, randomize the participant only if he or she meets all inclusion and exclusion criteria, obtaining blood samples for serum chemistry, hematology, hepatic function panel, and coagulation tests if greater than 1 day has passed since screening, obtaining the biospecimens and which include the blood collection, stool, saliva, and if available, urine and liver tissue. Dispensing the study medication and instructing the participant on medication dosing and administration. Instruct the participant to swallow the capsule whole. They must not open, chew, divide, or crush the capsule. Verbally instruct the participant and caregiver, if applicable, on the subcutaneous injection procedures, and provide the IRB approved instruction handout, and that the participant should remain fasting 8 hours prior to their next visit. To note that study medication will actually be dispensed if the patient is inpatient directly to the inpatient pharmacy. So, of course, we should always train the participant on proper subcutaneous injection and the other medication instruction. We will not be using the actual medication itself, the subcutaneous injections to instruct, but if you need to, you can have a dummy syringe minus needle just to kind of show them how to do things. And of course, if they are inpatient and they are discharged prior to day 14, you will probably have to go over the instructions again if you are able to do so. So our day 3 procedures, we will have physical exam, vital signs and weight, recording any emergent AEs, recording any changes to the medications, assessing the MELD scores, obtaining the blood samples for the safety labs, and the measuring of the GCSF and anakinra levels. They should be reminded again to fast 8 hours. We will be dispensing study medication again. This will be an additional prescription form, even if they are still inpatient. And if they are outpatient, please note that you will need to have their platelet and GFR to dispense, in addition to watching the white blood cell count. So if for some reason they are outpatient for the day 3 visit, I would suggest that you bring the patient in early enough that the labs can be resulted, that you are able to send the prescription to your investigational drug pharmacy. However, if they are inpatient, you still will need an additional prescription form. Day 7 procedures, similar to before, which is the physical exam, vital signs including weight, any AEs, any changes to medication, the MELD and LIL score, blood for safety levels, for safety labs, and the GCSF and antibodies, and stool, as well as urine and liver tissue if available, and assessing medication compliance. So one thing to note for the coordinators here, because we are blinded, the syringes are shaped in such a way that they are not all the same. And we will not be allowed to visualize or feel the syringe at all. So assessing medication compliance is going to be done for the subcutaneous portion anyway by patient report. So the medication log that we will give them. When the pharmacy, if they are outpatient before day 14 and the pharmacy is dispensing medication to you, it will be in an opaque bag. Any of the needle boxes that we give them, the sharps box containers, they must also be opaque. So we are just going to have to rely on patient report for the subcutaneous injection compliance if they are outpatient. And again, let me go back to day 7 quickly. I've been in discussion with our pharmacist here, the IDS pharmacist, Melissa Allard, who is overseeing the trial for all of the sites. We will have the availability to dispense on day 7, kind of an unscheduled dispensation. If their lab values are such that a dosage adjustment, so weight, the GFR levels, so if they meet those changes on our day 7, if they are outpatient, I know all of this will be rare, that they would actually be outpatient. However, we will have something in place that you'll be able to redispense sort of in an unscheduled manner that can account for these lab changes. Sorry, wrong way. So day 14, pretty much a repeat of the other days. They will complete the questionnaires. They will need another urine pregnancy test if it's applicable. Of course, recording any changes to the medication, any AEs, assessing the MELD scores, and blood for safety labs and biorepository labs, as well as stool and available urine and liver tissue. Again, remind them to fast and assessing the medication compliance. Day 28. So collecting, again, going over their alcohol consumption, any changes to their medical history they might have recalled, physical exam, vital signs and weight, the 3 questionnaires, assessing and recording emergent AEs, any changes to their concomitant medications, assessing the MELD score, obtaining blood samples for safety labs, biorepository, stool, and if available, urine and liver tissue. The participant should again be reminded that 8 hours is required fasting before their next visit. By the way, this stool is, I think it must be collected within 12 hours. So if you do send your patients home with any stool kits, if they're outpatient, just remind them it has to be within 12 hours if they're willing to bring that in. So we will dispense on day 28. This will be the 3rd study medication dispensation. Of course, this will only be capsules. It'll either be the zinc or the placebo for prednisone, and reminding them they must not open, chew, divide, or crust the capsule, and assessing their medication compliance. Day 60 and day 90, again, collecting alcohol consumption, physical exam, vital signs and weight, the 3 questionnaires, assessing for any emergent AEs, any changes to their medications, the MELD and LIL score, blood for safety labs, and stool, and if available, urine and liver tissue. Don't forget, on day 90, saliva and a blood sample will be collected for the antibodies. So, and again, reminding them to fast 8 hours prior to their next visit. Water is fine. Assessing their medication compliance. Day 180 is our follow-up. So we'll go over their alcohol consumption and medical history, physical exam, vital signs including weight, the 3 questionnaires, any emergent AEs, recording any changes to medications, assessing the MELD and LIL scores, and then blood for safety and biorepository labs, as well as stool. The DNA is being extracted from the blood again, and if available, urine and liver tissue. So, drug administration and compliance. I have included in here the 3 arms just for continuity that we went over before in the PI portion. So on day 0, after eligibility is confirmed, they will be randomized. In order to properly randomize and allocate a participant to treatment, the investigator or designee will be required to register the participant into the REDCap system. A randomization number will be assigned and study dispensing information will be provided, which you will need to put on the prescription form that you send to your investigational drug pharmacy. So then the coordinator will ensure that the participant understands the dosing and storage instructions for drug and disposal instruction for used syringes, and we will make sure we provide them with the subcutaneous injection instructions. If they are being discharged prior to day 14, please make sure that you also provide them with sharps containers, alcohol wipes, and Band-Aids. Again, those sharps containers must be opaque so that we cannot visualize the syringe as coordinators to maintain the blind. And then the participant will begin dosing on day 1 with the AM doses of oral and subcutaneous therapy. As it is written right now in the protocol to avoid potential interference with concomitant medications, we will administer the morning blinded tablet, which will either be the zinc or prednisone, at least 3 hours apart from other medications, and that the participant will take. So we are hoping to amend that to a very specific list of medication that must not be given within that 3-hour time frame to help ensure that the safety compliance is met, especially in inpatient situations. Might be a little easier outpatient to instruct the patient not to take anything within that 3-hour time frame. However, on inpatient units, we want to make sure that patient safety is accounted for. So Melissa Allard is again going to provide us with a very specific medication list that need to be avoided in that time frame. And of course, we will provide that once we have it and hopefully write that into an amendment. So I have seen the list. It's not that long as opposed to all oral medications at all. So hopefully we can make that work for patient safety. And then we will give them the IRB medication compliance log and instruct the patient on how to complete the log. Inpatient, obviously the medication will be noted in the electronic medical record. So this is more for outpatient use, although we can provide it to them, and if they have any issues, that'll be a good place for them to write it down. And just reiterate the necessity for honest compliance recording when they are outpatient. I like to tell my patients that, if we treat them for any emergencies, any health situations they may develop, we're going to treat them based on the fact that we think they are taking these medications. And it may be entirely different how we would look at them if they actually hadn't been taking them. So I just reiterate that honesty in recording their compliance is for their safety, most importantly. So don't tell us you're taking the drug or doing the subcutaneous injections if you are not. Participants should be instructed to retain all their study medication, even if it's empty, and return them to the investigator at the subsequent visit. So obviously empty sharps will be in the sharps container, but referring to the pill bottles and any unused syringes. Per section 2.13 of the protocol, at this time, it was listed that the investigator at each site will check for drug interactions between study drug and other concomitant medications for each participant. Because we are blinded, that would mean that we needed to check all 3 study medications against every concomitant medication that they are taking. However, again, with the help of Melissa Allard, she is compiling a very specific list of the drug-to-drug interactions between all of their concomitant medications and all 3 of the study drugs. So hopefully it will make it much easier for us as coordinators and to ensure patient safety that we have a very specific finite list that we'll be checking the con meds against, and we will also have a form in red cap that you'll be able to say that they are not on these medications. So if they are on one of those medications, you need to confer with your primary investigator. But this does include any and all forms of zinc, so that especially multivitamins, over-the-counter cold remedies such as your Zicam, things like that, they cannot have any additional zinc. It is actually a very big safety issue, so we will need to educate them on that. So the drug is being distributed on day 0. They will receive 1 bottle of oral therapy, which will be a 30-day supply blinded, and they will, as it stands now, they're having an AM bag and a PM bag. How this will actually be done, Melissa Harrell just kind of revised this. For one, if they're inpatient, it is going straight to your inpatient pharmacy for reasons we will discuss later. However, if they're outpatient, the syringes will actually be labeled for them, like Monday AM, Monday PM, by the pharmacy. So if lab results that we will discuss later necessitate placebo or an every other day dose reduction, the pharmacy will just redispense with, again, labeling the syringes AM, PM. So this is if they're outpatient. However, if they're inpatient, it's all being handled by the inpatient pharmacy. And that is because labs need to be checked every day before the medication can be given, and that's just not possible for coordinators 7 days a week, 365 days a year. So on day 3, again, we're going to send in another prescription. Even if they're inpatient, they will get a 9-day supply blinded of sub-Q therapy for days 6 through 14. And we will remind them to finish the syringes from day 0 before starting the syringes on day 3 if they are outpatient. We're going to ensure, by the way, that the medication log has both date and study day, because the syringes will also be labeled in that way. So it may not be Monday, Tuesday, maybe day 1, day 2, that kind of thing that they need to follow, especially important for every other day dosing. So we're going to need to make sure that we know what study day they're on and they know what study day they're on if they're outpatient for subcutaneous injection. And on day 28, we are dispensing another bottle of the oral therapy, which is a 60-day supply blinded. Any missed doses, if they miss a dose, we should instruct them to take it on the same day as soon as they remember, but preferably not longer than 6 hours after their normal dosing time. This is to avoid any unintentional overdose. Missed doses should not be taken on the subsequent day, so no doubling up on doses. If they miss a dose, they should just make a note of it on the medication compliance log, again, if they're outpatient. And I would also instruct your inpatient nurses to that it cannot be given closer than 6 hours after their normal dosing time. Continued trial eligibility should be assessed based on their compliance with the study medication and clinic visits. Because of all the safety factors, we really need to monitor people who are not completing their follow-up or being compliant with medication. So unblinding, again, we're going to be watching these patients very closely for safety. We did discuss this before with the PIs, but if there is a medical emergency that necessitates unblinding, the site investigator should contact Dr. Garway and discuss the rationale. And if there is a difference of opinion, Dr. Garway will defer to the site investigator. And the site investigator would communicate with the DCCIU about the decision to unblind, and then the DCCIU will unblind the participant. And they will interact directly with the designated site investigator. So you'll have a sub-I that is designated for unblinding information. Again, you will have emergency unblinded for sepsis, hypotension, any other serious adverse event. So the clinical care team can always request unblinding. I think we're going to provide everyone with contact cards you can give out for your local PI, for Dr. Garway, for the DCCIU, that kind of thing, just so that teams, hospitalist teams, that type of thing can get a hold of the site investigators and the necessary people in the event of an emergency. Again, only a designated site sub-investigator will be unblinded, along with the clinical care team and the DCC contact. Again, as we discussed, however, more than likely, if the clinical care team is unblinded, we will accidentally be unblinded as we're monitoring the patient in their electronic medical records. So we will provide you with a procedure to report your accidental unblinding. Drug holding and stopping. We did go over this before, but as coordinators, we will be watching these things very closely. So pneumonia, positive blood or acidic cultures for bacteria or fungus. We're only worried about the fungal cultures in urine. So be on the alert for that, because bacterial cultures are just so common. And then we're watching the SIRS criteria, defined as 2 or more abnormalities in temperature, increased heart rate, respiration, or white blood cell count, with the increase in the SOFA score greater than or equal to 2 points. And we will be reassessing the patient on the 3rd day after a study drug hold to see if the study drugs could be resumed or should be stopped. So to discuss that point further, they will be reassessed on the 3rd day of the study drugs hold. If the infection clears and the participant stabilizes, study drugs will be resumed. For participants with documented infection, if the infection is responsive to antibiotics and participant is stabilized or improved, study drugs may be resumed at the discretion of the clinical care team. If there is no improvement after 3 days, there's no improvement after 3 days, study drugs will be stopped. So for participants meeting only the SOFA criteria for stopping, if cultures of urine, blood, ascites, and stool, including C. diff, are negative and the chest x-ray is unchanged, study drugs may be resumed at the discretion of the clinical care team. If the participant has a second hold of study drugs due to infection SIRS criteria, the study drugs will be permanently stopped. And we are not using the little score as a criterion since we will be blinded. So drug stopping rules. If there is no improvement or stabilization after holding study drugs for 3 days, for a second hold of study drugs due to the infection SIRS criteria, if they develop a severe leukocytosis of greater or equal to 100,000, all of these are the rules for stopping the drug. So holding and stopping for DILI, if the MELD increases by 5 from baseline or the child score increases by 3 from baseline, plus a greater than 3-fold increase in ALT from baseline on 2 consecutive occasions. If there is a competing etiology and DILI can be excluded, study drug can be resumed within 3 to 4 days. And if DILI cannot be excluded, the study drug will be permanently discontinued. Additional reasons for study drug discontinuation, these include unexplained elevation in ALT greater than 5 times baseline, or greater than 500 units should be, I think, IU. Anyway, greater than 500. Unexplained elevation in AlcPOS greater than 3 times baseline or greater than 500. Treatment and holding and stopping rules for lab abnormalities. Again, as coordinators, we are going to be watching these extremely closely. If the platelet counts drop to 50,000 per milliliter or less than 50,000 while they are on the injectable study drugs, they will be held and resumed when platelet count is greater than 50,000 per milliliter. So the injectable study drugs will be held in that situation, not necessarily the oral. So that applies only to injectable. For worsening renal function, so as all patients are randomized to treatment arms while hospitalized, right now it says that the protocol says that the IDS will be checking the GFR before dispensing the study drugs for the day. We are actually dispensing on day 0, day 3, and day 28. And at our location, the IDS is separate from the inpatient pharmacies. So we are amending the protocol, and the inpatient pharmacies will be entering the GFR and platelets into the IU red cap, and they will be given instructions on what medications may be given. So whether or not the patient needs placebo or alternating dose. So in addition, as it is written now, the study coordinator would be responsible for notifying the IDS when a GFR drops to less than 30 but is greater than 20. And then as it's written, the IDS would check if the subject is on anakinra and then dose reduced to every other day. Because as we discussed in the prior scenario, we are only actually dispensing on day 0, day 3, and day 28. And at many locations, including ours, the IDS and the inpatient pharmacies are separate. In fact, our investigational drug is only in Monday through Friday during business hours. So to avoid any safety issues, so if the coordinator were responsible 7 days a week, 365 days a year, including holidays, we would have to check the safety labs for the morning. So at our location, I would have to get up at 4 a.m., hopefully be able to get into our medical record system, wait until the labs are resulted. So whatever time they result, if they resulted by 4, great. If not, I have to continuously be watching them. Then if the safety lab level were met, I would have to get hold of a pharmacist, a nurse, because pharmacy isn't actually dispensing. What I'm getting at is you can see there would be many safety obstacles to making sure that system worked. So the amendment should be that the medication will be dispensed from the investigational drug pharmacy on those day 0 and day 3 to the inpatient pharmacy, and that every day the inpatient pharmacy will check the labs that have been done for that day and put in the appropriate numbers, and then they will be instructed on what medication should be given. Also, to that note, Melissa Allard also pointed out, while our protocol only has need for the safety labs to be resulted at certain visits, we will be amending the protocol to state that we need to make sure that the labs, so at our location, the GFR, it would be the basic metabolic panel and the platelets, are resulted every day, because the pharmacy will need to put those in every day so that the patient gets the correct medication. So that is something we need to watch. Of course, even though we're not responsible for following these safety checks as coordinators for medication dispensation every day, obviously we will be keeping a close eye on the patient's daily labs as coordinators to make sure that these other safety implementations are followed. So if the GFR drops to less than 20 milliliters a minute, the patient will not be dose reduced. The study drug will be held and substituted with the placebo. So if the patient is outpatient, I have it written here that they'll be in daily bags. It'll actually be, as I said, labeled, let's say they're on day 7 a.m., day 7 p.m., day 8 a.m., day 8 p.m., and so forth, and to enable the pharmacy to either substitute with every other day or everyday placebo if needed. We all acknowledge that it would be very rare for somebody with a GFR of less than 30 to not be hospitalized, but we want to make sure that all scenarios are covered so that the coordinators don't have to scramble at the last minute if a scenario comes up that we hadn't accounted for. This is also why I mentioned the day 7 kind of unscheduled dispensation or any day unscheduled dispensation of study medication due to these lab values that necessitate placebos or stopping. So every other day dosing or stopping and replacing with placebo, we need to make sure that any day that we get those labs back, days 1 through 14, that we have the ability to substitute as we're supposed to if they are outpatient. Again, inpatient, it should be all covered, but outpatient, we just want to make sure that any scenarios, the coordinators have a way to do what they need to do. If you can think of other instances that we haven't thought of, please, again, by all means, report to us suggestions, comments. It's very important that we hear everybody's input and struggles that they're having so that we can make the changes to make it better. So, reasons for mandatory trial discontinuation for patients: the persistent infection, as we have described before, pregnancy, although it is not an SAE, obviously they are withdrawn from the trial and followed as long as deemed appropriate. Clinical deterioration. So if the Maddrey's discriminant function increases by 5 and also exceeds 32, or the MELD score increases by 5 and also exceeds 20, the study medication should be stopped. However, the participants will remain in the trial, completing procedures as detailed in the schedule of procedures. The study drugs will be stopped if severe leukocytosis of greater than 100,000 develops. Treating physicians may offer any other treatment that is considered as medically indicated and appropriate. So the study medication will be stopped. The participant can still complete all study procedures. And of course, suspected drug-induced liver injury, as we discussed before. Protocol deviations. We did go over this before. There will be study protocol deviation forms. It's just important that if there is a safety, if a deviation affects patient safety, that IU is notified within 2 working days. And just for note, because this has happened in previous trials, a deviation from inclusion and exclusion cannot be written up as a protocol deviation. You must clear that with WERB prior to randomization. So you must get an exclusion criteria or inclusion criteria deviation approved by WERB prior to actually enrolling the patient. miss visits. So if they don't return for their follow-up visits or any of the clinic visits within the visit window, it will be considered missed. Complete the follow-up cover sheet form or the visit cover sheet form. Call the patient using the medical record follow-up and the phone script form. If they don't answer, use that form and check the medical records. Mark the visit as missed in the space provided in REDCap and enter it in the data form. Complete the subject protocol deviation form as well. Early termination, if they withdraw consent or discontinue treatment prematurely during the treatment phase, they should complete the assessments required at day 16. Note, this is how it's written, but just to reiterate, if a patient withdraws consent, no study procedures may be done after consent is withdrawn. However, you can actually ask them if they are willing to complete the day 60 procedures before they formally withdraw their consent. However, there's nothing we can do if they withdraw consent. But if they discontinue treatment prematurely, you can do the assessments required at day 60. If they discontinue prematurely during the follow-up phase, do the assessments required on day 180. So then you would complete the procedures for early termination, complete the end of study form, and enter it all into REDCap. If a patient is lost to follow-up, please notify the study designated physician, which would be Dr. Garre or his designee, as soon as possible if any participant prematurely discontinues from the trial. The date when the participant is withdrawn and the primary reason for discontinuation must be recorded in the REDCap CRF. Additional information may be requested to complete a discontinuation narrative. The participants will be considered lost to follow-up only after reasonable documented attempts to reach the participant prove unsuccessful. In all cases, a reasonable effort must be made to determine the reasons that a participant fails to return for required trial visits or discontinues from the trial. If the participant stays in the study but discontinues study medication, either by their choice or the investigator's decision, then study measures should be performed according to the scheduled trial procedures, rather than expediting those study visits or measurements. Patients will be followed until the final evolution, the stability, worsening, or resolution of the event that invoked drug discontinuation, and followed until the end of the trial if they are willing to do so. AE/SAE reporting, we did go over this before, but just a little more in depth. So all AEs and SAEs, whether observed by the investigator, reported by the participant, noted from lab findings, or identified in other means, will be recorded from day 0 until the trial completing of trial participation at day 180. AEs will be labeled according to standard medical terminology. We are utilizing MEDRA, using the case report forms provided. A TEAE, treatment emergent adverse event, is an AE that newly appeared, increased in frequency, or worsened in severity following the initiation of study medication. The definition of a serious adverse event is an adverse event or suspected adverse reaction is considered serious if, in the view of the investigator, it results in any of the following outcomes. Death is life-threatening, results in persistent or significant incapacity or substantial disruption of the ability to conduct normal life functions, a congenital anomaly or birth defect, requires in-participant hospitalization or prolongs an existing hospitalization, or is an important medical event that may jeopardize the participant or participant and may require, sorry for that typographical error, jeopardizes the participant and may require medical or surgical intervention to prevent one of the outcomes listed above. The investigator will document his or her opinion of the relationship to the AE using the criteria outlined in the table below. Again, reasonable possibility means that there's evidence to suggest a causal relationship between the study medication and the AE. So these classifications for SAEs that are common in severe alcoholic hepatitis, they are not meant to limit us to the SAEs that we are reporting. They are just given within the protocol for education. So just for reference, we are recording any SAEs or AEs that present themselves. We are not limited to these definitions. But these are just common in alcoholic hepatitis. So acute kidney injury, sepsis, infection, decompensation of liver disease, hepatic failure, cerebral failure, renal failure, respiratory failure, circulatory failure, and multi-organ failure. To note, sepsis will often be an SAE that precedes documented infection by 1 to 5 days. If the sepsis is reported as an SAE and infection is never documented, then it should be classified separately. For example, sepsis with documented infection or sepsis without documented infection. And sepsis can be diagnosed by manner changes in lab parameters, such as these listed below. SAE reporting, this is a repeat of the slide before, so just make sure to report them within the 2 working days of the investigator becoming aware. And the investigator should make an initial telephone report to Dr. Garre, but also an email with at least the basic criteria of the 5-digit study IDA, description of the event, the criterion for classifying as serious, and the name and title of the reporting individual should be sent within 2 working days. This table is given so that you can see who to report it to and in what time frame for all AEs, SAEs, SARS, etc. This is also a schematic for when and who to report things to, with the additional information of the phone numbers below. Contact list between all our sites. And nice little slide for reference of SAE reporting. So unscheduled safety visits, of course, that the investigator may schedule an at-clinic unscheduled safety visit at any time if clinically warranted, and unscheduled and/or repeat assessments may be conducted. As appropriate, the designated study physician should be contacted. So Dr. Fowler should be contacted if an unscheduled safety visit is needed for a patient, just for safety monitoring, so he's aware of what is going on. We went over the pregnancy recording. It's not an SAE, but study drug will be stopped and they will be followed till the what time frame Dr. Garre and the site investigator determine, and it must be reported to WERB per their guidelines, but it is not an SAE. DSMB, who's on it, what their contact information is. So study monitoring as part of the protocol, and as is required by all investigator-initiated IND holdings with the FDA, we will be having clinical trial monitoring. This will be risk-based monitoring. It will all be done remotely for the most part, unless additional needs warrant. So as with typical monitoring, they will have kind of a site initiation visit with all the sites. Again, this will be an independent individual that has not been designated yet, but it will not be anyone already currently involved with the trial. So they will have a site initiation visit. They will be doing risk-based monitoring throughout the study, and they will have a study closeout visit. Again, these are all intended to be remote unless needs warrant for on-site. So for their site initiation, the requirements will be that they go over study procedures at the site. We'll just acknowledge that the protocol has been reviewed. If they want to go over brief things about the protocol with you, they will, but it should not be in depth like this. Randomization procedures, enrollment expectations, timelines, subject information sheets and informed consent processes, subject patient assessment procedures, specimen handling, central and local lab procedures, and subject termination, withdrawal, replacement procedures. They'll go over study drug handling, probably with your pharmacy in addition to your staff on site. They'll go over study documentation. They'll be monitoring the REDCap for CRF completion. They will be entering queries and ensuring that they are answered in a timely fashion, that the data flow process and discrepancy report handling is done, AE and SA reporting. They will be verifying source documentation by having you redact source documents and email most likely to them. And they will inquire about your archival procedures and that all IRB requirements are met. They will also be checking to make sure that the good clinical practice has been completed, that their monitoring requirements will be that they are doing these things, and then that the delegation of authority, who is on the delegation authority within the clinical site, so they know who to inquire with. So additional monitoring will be triggered by issues with recruitment, medication adherence, protocol violations. So that would be excessive or severe protocol violations. If the adverse events, serious adverse events are high, they'll need additional monitoring. Laboratory quality control, issues with biorepository submissions, these are all things that might require them to do additional monitoring. Action levels, so they will have action levels that will be triggered if things aren't going as they should, or if if the monitor feels that there are issues, they'll have a verbal discussion with the coordinator. If things aren't resolved after that, they will have a verbal discussion with the site investigator and will send follow-up documentation. The next level, if things aren't resolved, is a written warning to the site investigator. The next level, if there is no resolution to the issues, is an actual on-site visit with the preparation and signing of a remedial action plan, which will be reported to the steering committee and the DSMB. And the fifth level, if there's no resolution, would be the suspension of the site recruitment until everything is satisfactorily resolved. Regulatory resources. So all of the source documents will be on Box, similar to the AlcHepNet observation, will be the same area. And knowing which forms are needed for each visit, there will be a cover sheet form that our REDCap team, Jacob, is, will have for us to make it easy. This is just a rundown of what should be in your regulatory binders. And these binders will also be checked remotely by the site monitor. Again, redacting any PHI, but it'll just be scanned and email to them. These resources will be in our Box folder. Form completion guidelines, just to quickly go over the standards, changing a response on a form appropriately. So just to cross out one line and then initial date with an explanation in the margin if need be. And if there are multi-page forms, making sure there's a header on each page. Numbers should be right, justified. And if you're using the CRF forms as source documentation, if you're using them as you complete the visit, like writing it directly on the source document, the CRF forms, it's great. If you use any other source to complete, please make sure that it is in your source document binders study file. Quite some contact. Savannah and myself, Jen Lehman, as just protocol contacts. For biospecimens and labeling issues, Candace and Peter at UMass. For RUDCAP, Jacob Hell here at the IUDCC. And for regulatory questions, again, Savannah and myself. Any questions or concerns, please do not hesitate to email, call, whatever you need. We would like to make sure that the study is as easy going as we can possibly make it. We know this is a very complicated study for all of us. We appreciate everyone's efforts, and everyone's thoughts and opinions are highly valued. So please keep track, again, of apologies, of not only any issues you have with completing the protocol procedures as required, but barriers to enrollment, that type of thing. Please document those and send them to us. It will help move forward any amendments that need to happen or be discussed based on those items. So we do appreciate you doing that. Here are the links to all of the scores. So please utilize these links for the score completion. This is what the medication log will look like. You can see that it has a space for the day of the study trial as well as the date. This will be very important for study drug labeling when it comes to the syringes. This is the current format of the IRB medication form. This is just for reference. And the labeling of the tubes and the aliquots. So I wanted to thank you all for listening to this. And if you have any questions or concerns, again, please do not hesitate to call or email. Thank you and have a great day.